Hello, everyone. So let's start our first week with fetal circulation. The fetal circulation, it's a specialized circulatory system in developing the fetus, and its purpose is to deliver oxygen and nutrients from the placenta while bypassing the non-functioning fetal lungs and partially bypassing the liver. So, okay, what I want you to do is just follow the numbers that I basically wrote and the highlighted areas, okay? And follow while I'm starting from the umbilical vein and we end with umbilical arteries. So the umbilical vein, which is number one, carries oxygenated blood from placenta to fetus. Then we have the number two, ductus venosus, who's responsible of shunting blood from umbilical vein to inferior vena cava by bypassing the liver. Number three, we have the foramen ovale, which is responsible of shunting blood from the right atrium to the left atrium. Then number four, we have the ductus arteriosus that shunts blood from pulmonary artery to the aorta. And then we have the number five, which is basically umbilical arteries that they carry the oxygenated blood to the placenta. And now I will talk about just step-by-step pathway of fetal blood flow. And it's basically, I'm going to repeat the structures that I already mentioned. So oxygenated blood returns from the placenta via the umbilical vein, where basically the oxygen saturation is approximately 80%. 50% of this blood bypasses the liver through the ductus venosus and enters the inferior vena cava. And the other half perfuses the liver before joining the inferior vena cava via the hepatic veins. The inferior vena cava delivers the mixed but relatively oxygenated rich blood to the right atrium, and the blood from the right atrium is directed by the Eustachian valve through the foramen ovale into the left atrium. From left atrium, the blood goes to the left ventricle, then into the ascending aorta, and here it supplies coronary circulation, brain, and upper limbs. This ensures basically the most oxygenated blood reaches the vital organs. And the vital organs, as you know, are brain and the heart itself. The oxygenated blood from the superior vena cava, basically from that delivers blood from the head and upper limbs, enters the right atrium and then flows into the right ventricle. The right ventricle ejects this blood through the pulmonary artery, but since there is a high pulmonary resistance, 90% of this blood is diverted through the ductus arteriosus into the descending aorta. And then descending aorta supplies the lower body, and most of this blood is returned to the placenta via the two umbilical arteries. During the transition at birth, there are specific triggers that they cause a shift in the circulatory system. So the first breath causes the lungs to expand, and this in turn causes decrease in pulmonary resistance. Moreover, there is the clamping of umbilical cord, and this causes an increase in systemic resistance and decreased blood return to the placenta. Now let's talk about the mechanism that basically causes the closure of foramen ovale, ductus arteriosus, and ductus venosus. The foramen ovale closes since there will be an increase of left atrial pressure, which is higher than the right atrial pressure. The ductus arteriosus closes due to increased oxygen and decreased prostaglandins. And last but not least, the ductus venosus closes due to decreased umbilical flow. These changes make sure that blood now flows through the liver and lungs as in postnatal circulation. At birth, there are several clinical changes that occur. The baby takes the first breath, and this causes the lungs to expand, which in turn causes a drop in pulmonary resistance. There is increased blood flow to the lungs. Therefore, there will be more return to left atrium. The foramen ovale closes and it becomes fossa ovalis. The ductus arteriosus constricts due to rising in oxygen level and drop in prostaglandin, and it becomes ligamentum arteriosum. And ductus venosus closes and it becomes ligamentum venosus. And umbilical vessels also close and become just ligaments. Our next subject is basically persistent pulmonary hypertension of newborn, the PPHN. The basically persistent pulmonary hypertension of the newborn is a condition where a newborn's circulation continues to bypass the lungs after birth, which results in severe hypoxemia. So, in fetal life, as I mentioned previously, the pulmonary vascular resistance, the PVR, is pretty high, and only 10% of blood flows to the lungs. Oxygenated blood from the placenta bypasses the lungs via foramen ovale and ductus arteriosus. And at birth, as we already know, lungs expand, the pulmonary vascular resistance drops, and pulmonary blood flow increases. Moreover, there is a functional closure of foramen ovale and ductus arteriosus. In PPHN, the pulmonary vascular resistance remains high, maintaining a right to left shunting. Now, on this slide, you can see sometimes the cause of PPHN is idiopathic, and what happens, we have the pulmonary vasoconstriction and remodeling, and this will cause an increase in pulmonary vascular resistance and an increase in right to left basically shunt through PFO and PDA. let's take this path first. So the increased pulmonary vascular resistance causes the right ventricular hypertrophy and dysfunction. And this, on its turn, causes septal deviation and ventricular interdependence, which consequently causes the left ventricular dysfunction. And this, in return, will cause an increased pulmonary venous pressure, increase in pulmonary venous pressure, and increased in pulmonary artery pressure. Other causes of PPHN during the perinatal period of time can be asphyxia, meconium aspirate, lung hypoplasia, and congenital diaphragmatic hernia. And in neonates, the causes of PPHN can be respiratory distress syndrome, sepsis, pneumonia, transient tachypnea of the neonate, and Ehrlich syndromes. So these will cause a VQ mismatch and intrapulmonary shunting, followed by hypoxia, acidosis, and increase in vasoconstriction, which will cause again increased pulmonary arterial pressure. The decreased blood flow in pulmonary and decreased pulmonary venous return will affect the preload in left ventricular in the left ventricle, and it will further result in left ventricular dysfunction. So as you can see, there are different causes of PPHN. Now, the clinical features of PPHN, the onset is typically within 12 hours of life, and there is tachypnea, grunting, nasoflaring, cyanosis, which often is pretty severe and refractory to oxygen. The preductal and postductal saturation difference is more than 10%. It's basically comparing the right hand, which is the preductal, versus the foot, which is postductal. And there might be also signs of right heart, basically strain, which is hepatomegaly and tricuspid regurgitation. Now, whenever there is a clinical suspicion, we have to investigate. And this investigation basically consists of preductal versus postductal saturation gradient and hyperoxia test, in which by giving 100% of FiO2 for 10 minutes, the PaO2 remains less than 100 millimeter mercurium, and this suggests PPHN. By performing a chest X-ray might show normal lungs, or if there are underlying causes like meconium aspirate or congenital diaphragmatic hernia or respiratory distress syndrome, that can be revealed in chest X-ray. However, the gold standard is the echocardiography, in which we can appreciate right to left shunting across the PDA or PFO, elevated right ventricular pressure, and moreover, it will also we can rule out through the echocardiography, the congenital heart defect. In regards to management, there is the supportive care. Basically, we have to maintain normal thermia, normal glucose, and also normal electrolytes. Minimal handling of the newborn in order to reduce the pulmonary vasoconstriction, and mechanical ventilation if needed. And in this case, there is also an aim towards permissive hypercapnia. The treatment for PPHN consists of basically oxygen, which, remember, oxygen is a drug, okay? And this causes pulmonary vasodilation. And we aim usually a PaO2 between 60 to 100 millimeter mercury. Then there is the inhaled nitric oxide, the INO, which is first line, and it is selectively pulmonary vasodilator. And most of the time, it is started with 20 parts per million. Then there is sildenafil, which is either oral or IV, which is basically phosphodiesterase inhibitor, and it causes vasodilation. Milrinone can also be helpful in causing vasodilation, and moreover, the milrinone, it helps also the right ventricle. In the summary, basically the key points for PPHN are basically the PPHN is a failure of normal postnatal circulatory transition, presents with refractory hypoxemia and pre-post ductal saturation difference. The echocardiogram is diagnostic. Inhaled nitric oxide is cornerstone of therapy, plus supportive care and treating the underlying cause are the essential points. Our next slide talks about inhaled nitric oxide, and this, I'm pretty sure that you are pretty familiar with this, basically with these figures. The nitric oxide, it is highly reactive and short-lived free radical gas, and usually its biological half-life is matter of just a few seconds. The key points with nitric oxide in the body, it's quickly inactivated by binding to hemoglobin or reacting with reactive oxygen species. And despite its short half-life, its effects can be long-lasting through signaling pathways, especially in blood vessels, that causes vasodilation. So how is it delivered? Well, if the patient is intubated through the ventilator, basically through the circuit, and there are times that, well, in different occasions, different pathologies, it can also be delivered through BiPAP or also high flow nasal cannula. And when it comes to weaning steps, that differs based on hospitals' policy and procedures. An important point of nitric oxide is the methemoglobin, that it is produced when hemoglobin undergoes oxidation to its ferric form, leading to a leftward shift in the oxyhemoglobin dissociation curve, which reduces hemoglobin's capacity to bind with the oxygen. So we have to always keep an eye in the formation of nitrogen dioxide, which is basically the NO2, or the superoxide forming peroxynitric. Our next chapter is meconium aspiration syndrome. Okay, as you can see, this is a chest x-ray of meconium aspirate, and on the internet you can find several different x-rays. Okay, and here, as you can all see, it says bilateral coarse opacities and areas of atelectasis that alternate with areas of overinflation. I will give you a few seconds just to look at this chest x-ray, and then we will go to our next slide, which basically we will talk about the meconium aspirate. So meconium aspiration syndrome is a respiratory disorder that occurs in neonates that inhale meconium-stained amniotic fluid, also known as MSAF, either in utero, during the labor, or immediately after the birth. And this will result in mechanical airway obstruction, chemical pneumonitis, surfactant dysfunction, and pulmonary hypertension. And now I will talk about the pathophysiology of meconium aspiration syndrome. So meconium in the lungs causes a complex cascade of issues. One of them is the airway obstruction. The meconium is a thick and sticky material, okay, that can partially or completely block airways. It leads to a ball valve effect, that is, air gets in during inspiration, but trapped during expiration, which will cause hyperinflection or an airlick-like pneumothorax. It can cause chemical pneumonitis because meconium irritates the lung tissues, okay, and triggers inflammation. The inflammation will cause edema, bronchospasm, and alveolar damage. Moreover, meconium disrupts surfactant, and this will impair alveolar expansion, which in return will cause atelectasis, decreased compliance, and poor gas exchange. And last but not least, it will cause pulmonary hypertension. And the pulmonary hypertension, as you already know, will cause vasoconstriction of pulmonary vessels, which will lead to right to left shunting across foramen ovale and ductus arteriosus. The risk factors for meconium aspirate are post-term pregnancy, basically when the pregnancy lasts more than 41 weeks, fetal distress or hypoxia, oligohydramnios, prolonged labor, maternal hypertension, diabetes, or infections, and also intrauterine growth restrictions. On this slide, you can see there are some of the symptoms that are included, like the respiratory distress at birth, grunting, nasal flaring, intercostal retraction, cyanosis, decreased oxygen saturation, coarse breath sounds, and barrel-shaped chest, which is basically due to air trapping. And then on the X-ray, we can see patchy infiltrates and areas of atelectasis and hyperinflation. Hyperinflation, ropey or streaky densities, and the presence, if there is an air leak, presence of pneumothorax or pneumomediastinum. And next, here basically we have the meconium aspirate that, as I mentioned, can cause mechanical obstruction, air trapping with uneven ventilation, air leak, which will lead to hypoxemia and acidosis, same as uneven ventilation will result in hypoxemia and acidosis. The meconium aspirate can cause chemical inflammation and also surfactant inactivation, which will cause atelectasis, intrapulmonary shunting, hypoxemia, acidosis, which will cause then, at its turn, primary pulmonary hypertension. And when it comes to the treatment for meconium aspirate, well, oxygen therapy, positive pressure ventilation, which can be through non-invasive CPAP, or mechanical ventilation, surfactant therapy, if it is indicated, which will improve lungs compliance, nitric oxide, if there are signs of PPHN, and in severe cases, when the patient is refractory, presents refractory hypoxemia, it can lead to ECMO. Our next subject is congenital diaphragmatic hernia. And basically what happens is that in congenital diaphragmatic hernia, there is a developmental defect in the diaphragm that involves the protrusion of abdominal organs into the thorax. The key clinical feature of CDH are underdevelopment of the lungs, in other words, pulmonary hypoplasia, and abnormal development of pulmonary vasculature, which basically causes primary pulmonary hypertension in the neonate. As a matter of fact, pulmonary hypertension and pulmonary hypoplasia occur as a direct consequence of the herniation of the abdominal content into the thoracic cavity and the resulting compression of the growing lungs. The size of this defect and the degree of pulmonary hypoplasia and PPHN determine the severity of the condition, which can be life-threatening. Mainly there are two kinds of congenital diaphragmatic hernia. which are basically the left CDH and also the right CDH. Rarely they are basically at the both sides. However, as you can see on this slide, this is the right-sided congenital diaphragmatic hernia, which is more common compared to the left-sided congenital diaphragmatic hernia. There you go. And this is basically the intestinal basically content, the abdominal content that it is present on the right side of the thorax, and on this other chest x-ray, it's basically the abdominal content is in the left side of